Good evening. I'm Adil Barucha, and as President-elect of the American Neurogastroenterology and Motility Society, it's a true pleasure for me to introduce the moderators for today's symposium. Dr. Jason Baker is a pioneer in GI physiology testing. He served as a lab coordinator, the deputy director, and then the associate director of the GI physiology laboratory at the University of Michigan. He then moved on to Atrium Health, where he was a faculty member in the Division of Gastroenterology and Surgery. And currently, he's the senior manager of clinical training and education for ANMS Robotica. And his research portfolio really demonstrates a variety of interests in several disciplines. Those projects that are clinically centric, others that entail pharmaceutical pathology and biomedical technology. Laurie Keefer is a pioneer in the gastropsychology. She served at Northwestern University for many years, where she worked closely with John Pandolfino to really educate the entire field in the role of psychopathology and behavioral approaches for managing patients with these disorders. Currently, she's a gastropsychologist and a professor of medicine at the Icahn School of Medicine at Mount Sinai, where she oversees the integrated care of over 12,000 patients living with Crohn's disease and ulcerative colitis. She's truly internationally recognized for her work in promoting the science of psychogastroenterology and the role of gut-brain behavior techniques in the management of disorders of gut-brain interaction. I hope you enjoy this symposium as much as I look forward to it. I'd like to thank Laurie Ennis and Stephanie Twist, who really put these seminars together. And just a reminder of the meetings, the ANMS clinical course, which is going to be held in July 2024. And I'd like to encourage you all to become members of the society if indeed you're not already. There are a variety of benefits. We really exist to serve your needs. And so if there's anything we should be doing that we're not, please don't hesitate to drop us a note. And with that, I'll turn it over to you, Laurie and Jason.
Well, thank you for Dr. Barucha for the kind introduction. Thank you, everybody, joining us this evening. It's a true honor and pleasure to be co-moderating with a really good friend of mine, Dr. Laurie Keefer. And I think we're for a very good evening from Dr. Helen Burton-Murray for her guidance and pearls of wisdom on this particular topic.
Thank you. Yes, it's such a pleasure to co-host this with Jason, and I also want to thank the ANMS for their contributions to the field of gastropsychology. Without the gastroenterologists promoting the role of brain-gut behavior therapies and psychogastroenterology, we really wouldn't be able to do the work that we do. And so it's a real pleasure to be able to introduce Helen Burton-Murray, PhD, who is a clinical psychologist at Harvard Mass General Hospital. I've known Helen for a long time, and I can say that she really is somebody that everyone wants to aspire to be in terms of her ability to connect the brain and behavioral interventions with the GI physiology and pathophysiology. She is an assistant professor at Harvard Medical School and the director of the Mass General Gastrointestinal Behavioral Health Program. Her clinical research, which is NIH funded, is focused on the intersection of functional motility disorders and eating disorders, which we see very commonly in our patient population, including development of behavioral health treatment. So she's going to be really talking today, practically speaking, pearls of wisdom of not only how to be a gastropsychologist, how to use gastrointestinal testing and particularly motility testing to inform your approach as a psychologist, but also to really identify some of the ways in which a psychologist can be integrated and work with the gastroenterology professional. So it's my pleasure to introduce Helen and Dr. Murray, and I look forward to her talk.
And then the attendees, if you could put your questions in the Q&A app on the bottom, Dr. Laurie, Keefer, and I will go through them at the end with Helen to answer as many we possibly can.
All right. So here are my disclosures. I'm not going to be talking much about rumination syndrome today, but I do have a book which I receive royalties from. So I was given the unique challenge also of providing you with pearls of how to integrate motility and neurogastro testing into brain gut behavior therapies, but how to get to a place where you can do that and how you can learn to do that. So I framed my pearls today based on my experiences to get to where I am today and integrating these procedures and understanding gut function and how it applies to brain gut behavior therapy. Before we get there, I'm going to first just give a brief primer on what brain gut behavior therapies are, or BGBTs, for those who may not be familiar. So BGBTs are time-limited interventions that are targeted at GI symptom processes, particularly behavioral, cognitive, emotional factors that can contribute to gut sensorimotor dysfunction. They're between usually 4 and 8 sessions. The two most commonly known approaches and used in ambulatory care settings are cognitive behavioral therapies and gut-directed clinical hypnosis. And the number needed to treat for those two is around 4. I highly encourage you to take a look at an article that was written recently by Dr. Laurie Keefer and colleagues on what the different types of interventions that exist are and the possible mediators or mechanisms through which they work. This figure just shows that BGBTs and some different categories of them, the processes on which they may function. For example, some cognitive behavioral therapies may target fear conditioning and interoceptive learning processes that we believe can then improve GI symptoms. The end goal is improving GI symptoms. Another way to look at this is within the or underneath the BGBT umbrella, there are different types of techniques that we will utilize. And as a psychologist, I think I spend a lot of time thinking about, well, which techniques am I going to pull out from under the BGBT umbrella? And what am I aiming to target? What process that could be contributing to this patient's GI symptoms am I aiming to target? And this figure just summarizes some of the techniques under that BGBT umbrella on the right side and the hypothesized targets through which they may work to improve GI symptoms. An example of this are exposure techniques, which have been shown to decrease anxiety around symptoms and avoidance behaviors around symptoms to mediate symptom improvement and IBS patients. Today, though, we're going to be talking about how we can use neurogastroenterology and motility procedures and target motility function with brain gut behavior therapies. And so on the left here, I just have various symptoms that may apply. To the right, neurogastromotility functions that we may get from some of our procedures available and tests. And so first, I'm going to talk about how we might be able to inform possible targets from SITS marker studies to evaluate colonic transit. And then I'll talk about diaphragmatic breathing and for whom we might think this is effective and how to talk about patients why diaphragmatic breathing may be effective for their specific esophageal symptoms. And then finally, I'm going to talk about food exposure and the relevance of it in improving dyspeptic symptoms via improving gastric tolerance and accommodation. So as I mentioned, I'm going to kind of frame each of these examples of how to apply neurogastromotility functions in the context of pearls of how to get to the point of understanding how you can apply under these procedures in brain gut behavior therapies. And my first pearl is finding people who are willing to teach you. This has been huge for me. And I think that today I'm going to be highlighting individuals who help me specifically understand neurogastromotility procedures and functions, but there are so many others out there who have been helpful in guiding and supporting me throughout my career. Back in 2016, I did not know what a gastric electromyography scintigraphy was. And Henry Parkman taught me how to understand a GES study and influencing how we think about gastroparesis and functional dyspepsia and the controversies around using GES as well as the spectrum of functional dyspepsia in gastroparesis. I then got the opportunity to really see different types of esophageal manometry testing, and particularly how high-resolution esophageal manometry with impedance testing could be used to potentially differentiate gastroesophageal reflux from rumination syndrome. And this was through opportunities with Dr. Ahmad at Drexel Med at the time, and a formal practicum experience that I sought out with a gastropsychologist, Dr. Carrie Baber at CHOP, where I did once a week for a half day seeing patients in the clinic with her and having the opportunity to see how she integrated some of these motility studies into her encounters with patients and their families. And then finally, another pivotal moment for me was with anorectal manometry testing and other testing, including colonic transit evaluation with SITS marker with Dr. Kyle Stoller, where we formed a collaboration around looking at eating disorder symptoms in patients who are presenting for anorectal manometry. So the first example that I'm going to go through is how to think about SITS marker study findings with 2 patients who have constipation symptoms. And so we know that the number of retained markers on a SITS marker study doesn't necessarily correlate with the severity of a patient's constipation symptoms. And on the left here, we have an example of a patient with quote unquote slow transit defined by greater than 5 or greater markers retained when the patient presents for the scan at 5 days. And then on the right, we have normal transit. And in this picture, there aren't any retained markers that are present. But many patients will present with the same symptom profile, in this case, bloating, bowel movement 2 times a week, and having a range between hard and lumpy stool and close to more normal stool. And how I might think as a GI psychologist about differentiating what I'm going to be doing with 2 patients who have these same constipation symptoms, but their SITS marker study is different. Not going to actually change things too much necessarily. What I've highlighted in red here are some considerations that I have. So for the patient who has slow transit, I'm going to think about, do they have distress around feeling empty? And does that impact how I'm going to be educating them about in the context of their stool frequency and consistency, given that they have slow transit? It may be a little bit less of a concern than with the patient who has normal transit, but they're really, really distressed about not feeling empty. And I might be re-educating them with things that their GI provider has likely already told them about normal stool burden and how this test may actually be helpful in us identifying kind of the false alarm signaling that they're getting in their GI tract, and reinforcing the messages that there's a signaling problem going on between their gut and their brain. And we can use some strategies behaviorally to start over time changing their response to that signal. And then over time, decreasing how much they're distressed about that sensation, because we'll help the sensation go down. For the patient who has delayed colonic transit, I might be thinking, are there other factors that maybe haven't been fully assessed? And doing a formal evaluation of how much are they adhering to their medication. I remember countless times with Dr. Carrie Baber and even seeing one of my first scans of the Sitzmarker study that there was a patient who was taking polyethylene glycol, and we've identified that he actually wasn't taking it as the GI provider had recommended. And so using some motivational interviewing and trying to identify strategies that we could support him and his family to be able to follow adherence to taking the medication, which actually may help with the transit issue. My second pearl is doing as much of observation as possible. And so this may be through formal experiences that you can, from attending GI conferences, clinical symposia, workshops, more of these ANMS talks, to be honest. So even the Pearls of Wisdom symposia, but all of the other virtual symposia that the ANMS has put out over the past years have been helpful for me in being able to understand different types of testing that's available that my patients are coming in with, and being able to understand what the results mean for their treatment course. And so back in 2017 at ANMS, it was my first time seeing Laurie Keefer present with Dr. Abraham Khan and Dr. Satish Rao, where they did a live demonstration of high resolution esophageal manometry with diaphragmatic breathing. And then later on, I spent a summer at MGH actually sitting in on outpatient GI visits and hearing how my now colleagues, Dr. Kyle Stoller, Dr. Brad Quo, talked to patients about their symptoms, talked to patients about the results of motility studies, and how that was informing what their pharmacologic agent selection was, or other recommendations for behavioral or other therapies like pelvic floor physical therapy. And then in 2020, I became involved with the NIDDK Gastroparesis Clinical Research Consortium, and have learned so much about functional dyspepsia and gastroparesis, and more of the controversies in that realm, especially related to our understanding of gastric sensorimotor function in these disorders. So for this next example, I'm going to be talking a bit about diaphragmatic breathing and how I might use some of the tests that patients may have to inform whether I choose diaphragmatic breathing or not. And I'll preface this by saying that diaphragmatic breathing can be helpful for a large, if not almost all of our patients. The mechanisms through which just may vary. And so what I'm going to talk a little bit about is how diaphragmatic breathing may be helpful for different patient presentations with esophageal symptoms. For those who aren't familiar with diaphragmatic breathing, we're teaching patients a technique to bring more air into their abdominal cavity and less into the thoracic cavity, such that if they put their hand on their chest and their hand on their belly, the hand on their belly would go out and the hand on their chest would stay relatively still on an in-breath. And so with diaphragmatic breathing, supragastric belching is a very clear example where diaphragmatic breathing is believed to be a conditioned process in which air gets trapped in the esophagus and kind of gets forced back up. Versus gastric belching, diaphragmatic breathing isn't believed to have as much of this conditioned process, and thus diaphragmatic breathing may not be as helpful for these patients. This graph from Vlasinovic et al. Just shows a supragastric belch event and what's happening with air coming in, getting caught, and then going back up. Diaphragmatic breathing can also be helpful for reflux, and there's been more coming out about this for gastroesophageal reflux disease in the recent years. This study was just showing reduced reflux frequency compared to sham in both GERD and healthy controls. And so if you look just down in the graph, the control group is on the left in panel A and the patient groups in panel B. And we see that compared to the sham condition, there's on the left, and then the two bars on the right in each of the panels, there is a reduced frequency of reflux in those conditions. And so I might use some of this data and information to talk with patients about why diaphragmatic breathing may be helpful for their symptoms. And for gastroesophageal reflux in particular, there's some evidence from high resolution manometry that we can see reduced reflux potentially by changing the pressure difference between the lower esophageal sphincter and gastric pressure. There's also the possibility that diaphragmatic breathing may increase esophageal contractility, and is suggested that potentially even for patients who may have anti-reflux surgery, practicing diaphragmatic breathing before reflux surgery may help them afterwards have a better outcome. And so I talk about this. Dr. Baker and Dr. Keefer had suggested, don't talk about too much research and use these clinical pearls, but I truly will use this information that we have, this research evidence to support why I am recommending a certain technique for a patient and their symptom presentation. So it's not just, well, diaphragmatic breathing can be helpful for your symptoms. I'm going to use this information to describe the mechanisms through which why diaphragmatic breathing may be helpful for their GERD, for example, by increasing esophageal contractility, by changing the pressure difference between the lower esophageal sphincter and the stomach. And then finally, when I'm thinking, because many of these patients may have regurgitation, they may have supragastric belching, they may have gastroesophageal reflux, we'll kind of put things together into a conceptual framework for the patient to think about, well, what are the mechanisms that are maintaining your symptoms? And then how are we going to use this technique to target it? And in this model, this is for rumination syndrome. And on the left, we have secondary symptoms that a patient may have if they have comorbid supragastric belching and gastroesophageal reflux. And we talk about how the abdominal wall contracting may increase pressure in their stomach, then thus forcing contents back into their esophagus. And diaphragmatic breathing is a way to target that habitual process that's happening after they eat by relaxing the wall of the muscles in the wall of the abdomen, because you can't contract and relax the muscles at the same time. And then I'll bring in other mechanisms, which we're not going to talk through today, on the right side of other psychological or behavioral mechanisms that may be contributing to the physiologic process that we may add on in addition to the diaphragmatic breathing. So in sum, diaphragmatic breathing can be helpful, but we're going to use some of the evidence on why it may be helpful for certain symptoms to talk about the effect with patients to increase buy-in and potentially increase the utility of the intervention for the patient. My third pearl is to listen to what the areas of needs are for the patient population. And so largely that's patient experiences, listening to what the impact of their GI symptoms are on their functioning, any behavioral or psychological factors that you could identify from what they're doing around their symptoms, how they're thinking around their symptoms, how they're feeling around their symptoms that could be targeted by a behavioral treatment, and listening to clinicians' perspectives on how a GI psychologist can help. And so back in 2017, Brad Quo, I had met for the first time when I was giving a talk on rumination syndrome, and he honestly asked me, he's like, why are you focused on rumination syndrome? ARFID is something that is now a huge concern for us because it's now labeled for something that we're seeing in our patients, and we're hoping that there might be treatment specifically for restricted eating that can help our patients. And I started sitting in on clinic patient visits. And I would hear patients describe they can only eat small amounts of food, or they were having difficulty being able to keep up with eating throughout the day due to fear of having symptoms, or they just always were so sick of having pain around their symptoms and frustrated about that. Or they just kind of had lost interest in eating because of all of the discomfort and pain they had had because of their GI symptoms. So I went on to say, like, okay, well, how prevalent is ARFID in this population, and then try to figure out well, if it's a big enough of a concern with enough people who are having these issues, then what are the ways which a behavioral treatment could affect the processes that are keeping their GI symptoms going? So if we do improve their restricted eating, are there things that we could do to actually help with their gastric sensorimotor functions? And that led to my current grant funding through a K-23, where we're studying the nutrient drink test as a measure of gastric accommodation, or proxy measure of gastric accommodation, gastric transit with a wireless motility capsule, as well as satiety hormones to interact in the context of individuals who have developed issues with eating that meet criteria for ARFID in the context of functional dyspepsia. And so I think that with listening to, there are certain factors that you're hearing that patient is struggling with in the context of their GI symptoms that could be a target for behavioral treatment. Some of the things that I have done and I think have been helpful in figuring out the specific intervention components for these patients with ARFID and functional dyspepsia is identifying a hypothesized pathway for how a brain-gut behavior therapy can target or improve the processes contributing. So I keep on coming back to this, like selecting the technique based on the processes that can be targeted. And if this is already a known thing for the symptoms that your patient is presenting with, to learn about it, similar to the evidence that I was showing for gastroesophageal reflux. Looking at the literature to inform and understand the pathway further, and identifying ways to talk with your patients about how the brain-gut behavior therapy can target the processes. So with this example of gastric symptoms in the case of functional dyspepsia, we created a hypothesized pathway in our clinic for how targeting ARFID symptoms could actually improve gastric sensory motor functions that could be perpetuating functional dyspepsia symptoms. And through my work with patients at Mass General who have ARFID in the context of functional dyspepsia, as well as other disorders of gut-brain interaction, we were able to start working with patients to figure out which techniques might be most effective to improve their functional dyspepsia symptoms and affect these processes. So the treatment approach that I use to target these disturbances in gastric sensory motor functions is an exposure-based brain-gut behavior therapy, where on the non-neurogastromotility side, the targets are decreasing worry about symptoms and testing predictions about what the consequences of symptoms will be. And then we're using techniques to have them repeatedly approach rather than avoid, and have repeated kind of exposure to GI sensations by eating foods that they might be avoiding, increasing the amounts of food that they have, and with the hope that we're increasing ability to tolerate GI symptoms. On the neurogastromotility side, though, we're trying to target processes that could be contributing to their FD symptoms on a physiologic level. And particularly, I'm going to show for gastric accommodation and corollary tolerance, how we have been thinking about this. And so looking at the literature, there's some suggestion from a trial comparing mirtazapine to placebo for functional dyspepsia that we may be able to increase the amount someone tolerates of a liquid volume if we have them engage in a treatment where they're aiming to gain weight. So in this second panel below, those in the mirtazapine group had increased amount that they could tolerate of the liquid volume compared to the placebo. And this is an example of a gastric tolerance test or a proxy for gastric accommodation, where individuals are given a constant rate of a liquid nutrient, and then we see how much they're able to have over that period of time. And so I talk with patients about this concept of gastric accommodation intolerance, not necessarily in the context of having them do a nutrient drink test with me, but I talk about the process of what happens normally with their stomach when food comes into it, and so I show graphs and figures like this, with the stomach before food intake, and then the top of the stomach expanding with food intake. From my observations of clinic with some of my colleagues, like Dr. Kyle Stoller, I've been able to develop language like when food comes through your esophagus and into your stomach, the top part of your stomach, the fundus, is supposed to give it a big hug and hold the food there. And then over the course of the next couple hours, distribute it through the rest of the stomach before moving on to the small intestine. And even though that's simplistic language for the complex functions of the stomach, it can be helpful to set the stage for the brain gut behavior therapy to say, listen, like, we think that your stomach isn't trained right now to do what it needs to do. The good news is that we can retrain it. And we have some techniques that we'll be able to apply to help retrain your top of your stomach, the fundus, be able to accommodate to more food in one sitting. Because right now, when you are trying to challenge it, your stomach is probably like, whoa, like, we're not used to having this amount of food here, and then thus turning up the dial on GI symptoms. And so it's kind of like a gut PT approach is the terminology that we use. And I know others in the field have used that terminology for increasing kind of the amount of volume over a period of time to potentially improve symptoms. And sorry, Dr. Baker and Dr. Keefer, I'm just presenting a little bit more data, but we talk with patients about how we don't have randomized evidence yet to show that we can improve gastric accommodation with these techniques, but we talk about the ways in which we may be able to do so. And so this is just evidence from 7 patients in our clinic where we saw large reductions. All of the patients achieved a 1-point decrease, which is deemed clinically significant on the PAGI-SIM early satiety score. And so we use that kind of background of why they may be having symptoms due to impaired gastric accommodation, as well as other signaling issues between their gut and their brain, and then describe that we have some evidence that we may be able to improve your symptoms to support what components we're going to select to address the issues going on. And so in this simplistic table, I've put some of the targets that we're using with patients who have difficulty with eating in the context of their dyspepsia. And on the left is if patients are going long periods of time without eating, they're having issues with the frequency, we're going to have them eat by the clock. If they're having issues with eating amounts of food, we're going to gradually expose them to larger amounts of food, with including in-session challenges. And if they're having issues with the variety, we're going to work on increasing the food types. All of these things to try to retrain their gut. And so in summary, neurogastromotility procedure results may or may not inform selection of brain gut behavior therapies like I had talked about with the SITS marker results. However, talking with patients about how brain gut behavior therapy may improve their neurogastromotility function, I believe makes the behavioral therapy even more GI specific, where we're targeting processes that could be contributing to their GI symptoms, both behavioral as well as physiologic. And I'm happy to take questions in a moment, and just will leave up, I'll leave up this slide for you all if you are looking for resources on brain gut behavior therapies. There are a couple, this book, Psychogastroenterology for Adults, to find providers specifically. There are 2 search engines that have a broad scope of different providers, find cbt.org and locator.apa.org. And then RomeGIPsych.org has a GI specific resource for providers, as well as if you're a provider out in the community who's looking for more training in GI Psych, that's a great place for some resources as well.
That was fabulous, Helen. Seriously, it's just the connection. If anybody has any questions, they can put them in the Q&A box. We'll answer as many as we possibly can. And if we don't get to them as the session ends, they'll be continued on in Doc Matter. We'll provide the questions to Helen and Laurie to get answers back to you if we don't get to your question. But it's really fabulous. I think the idea that you presented of having this connection from patient being scheduled, patient having tests, patient getting results, and connecting that to the therapy that you're going to recommend. I think that is the pathway for the most success for patients. And I think by you taking, and I highly, commend you taking the effort of actually sitting in on these tests and learning them, maybe not at the expertise level, but enough to know like the results and how they're done and what they are instead of just contour plots. Really big 2 thumbs up to you for that. And I'm glad you stated that as a recommendation when you're building a program.
Yeah, and actually, I mean, I think that Jason's right. I mean, I guess as a for our physician colleagues that might be joining, our advanced practice colleagues, how do you set the stage before testing so that it doesn't feel like we've done testing and now we can't find anything, so we're sending you to the psychologist, right? Like, what is some of the framework of before we start with our motility testing that it may be that a behavioral intervention is appropriate?
And so I think to your question, Laurie, it comes back to how I was describing, well, diaphragmatic breathing can be helpful for supragastric belching and rumination-related regurgitation and gastroesophageal reflux disease. You don't necessarily need a test to be able to inform that diaphragmatic breathing will be helpful for all of those. I showed some of the esophageal manometry here and the graph of showing a supragastric belch to explain that we can use some information on how diaphragmatic breathing may affect the physiologic processes. But rumination syndrome, for example, is a symptom-based diagnosis. There's some evidence that using high-resolution manometry with impedance and having a certain cutoff for pressure and increasing gastric pressure could be used to differentiate GERD from rumination. But to be honest, in my clinical experience and including in our multidisciplinary clinic with our GI physicians, you don't need to order a high resolution manometry with impedance in order to diagnose rumination syndrome, and potentially same with supragastric belching.
Yeah, and Helen, this comes from Dr. Henry Parkman. He says, who is doing the physiologic tests that you may need to decide on the therapy, or do you use questionnaires?
Mm-hmm. Yeah, so part of this, of doing physiologic tests that you need to decide on therapy, I don't think that physiologic tests are necessary to decide on which brain gut behavior therapy. I think that if a patient has the testing, it may inform some of the techniques that you use, like the examples that I gave today. But it's not necessarily the case that the testing has to be done. If a patient does have a physiologic testing that's done, like a motility study, those in our group, we have a motility center that's led by Dr. Kyle Staller, and we have a team of motility nurses who actually are doing these studies with the patients. For the questionnaires, I do use a battery of questionnaires with patients, and we'll select certain measures based on their symptom presentation and the behavioral mechanisms that might be going on. So if they have anxiety around their GI symptoms, I'll be using that and use that several times over the course of our treatment. And then we also use symptom severity measures for their GI symptoms, and we'll look at those measures over time. That's how I had that data for those 7 functional dyspepsia patients, because I was using the PAGI-SIM with those patients in clinic.
Excellent.
And would you I mean, I guess some of the other questions that are kind of coming in are around that decision making, right? Around whether you would potentially do more of a diaphragmatic breathing, like sort of more of a technique based intervention versus a full on brain gut behavior therapy, gut directed hypnotherapy or cognitive behavior therapy. Can you talk us through some of the process of around which patients you think might benefit from one versus the other?
Definitely. And let me make sure. Okay, great. I've stopped sharing. Not all of our brain gut behavior therapies will work for everyone. And there may be different treatments that work for some patients, but not others. We don't have great data on this yet to inform how you select which ones for which patients. But I think one that is supported by some evidence is that patients who are higher in anxiety around their symptoms and higher in avoidance behaviors around their symptoms, I may be more likely to select an intervention like an exposure-based treatment where we're having patients approach their symptoms through exercises where we're experimenting with what they might predict is going to happen and learning, well, actually, maybe it wasn't as bad as I thought. Or maybe I could tolerate the symptoms that I did have in that situation, with the idea if we can have them engage in their life more and worry less about their symptoms, that may essentially hopefully send kind of signals down to their GI tract to say like, hey, cool it, like everything's good here, we're okay. So I may select that versus something else like a gut-directed clinical hypnosis, which I may select for a patient who is lower in anxiety symptoms. And then for specific techniques, I may, for each patient, will draw out specific techniques depending on what's present for them. So if a patient's in a weight suppressed state, they've lost a significant amount of weight and they're having difficulty eating around their symptoms, that's probably the first place that I'm going to start to help them gain weight, because their weight suppressed state could actually be having a negative impact on, say, slow colonic transit or gastric accommodation issues. And so gaining weight, in my opinion, may be the first step before we incorporate other strategies.
And Helen, we got about a minute and a half left, but this came from Dr. Barucha, and it's about it may need some deeper question answer after, but maybe good for the audience. How should clinicians gauge which patients should be referred and or more likely to be referred for psychological therapy?
Could you state the first part of that again?
Yeah, which patients should be referred and or more likely to be referred for psychological treatment?
Yeah, so I think that the first thing to consider is, have you talked with the patient about how a brain gut behavior therapy could be helpful? Because sometimes patients may just hear like, oh, like I'm sending you to a psychologist in the community or sending you to a psychologist on our team, and they may be able to help you. And for the patients who may hold stigma around seeing a psychologist or another behavioral health provider, they're likely not going to show up or follow through with that referral, or they'll show up and be like, like, I don't know why I'm here. Like my GI just sent me. And so I think making sure to have a conversation about like why a referral would be useful is the first step. And then that might help you identify, well, this patient, it might not be the right time, or brain gut behavior therapy might not be the right option for them if they say, you know, like that doesn't sound like me, I'm not willing to do it. So someone who's motivated to engage in a brain gut behavior therapy, or at least talk with a provider about the option so that we can evaluate what's going on with the patient, as well as provide education about how the treatment could help. So I think that's one key thing. And there are some other considerations that if you check out that Keefer et al. Paper, there are some other things that clinicians can consider of who's appropriate or not.
All right. Well, this has been fabulous. It's been a very fast 45 minutes, Helen. As a community, ANMS community, we really commend all your hard work. And Laurie, it's been a pleasure co-moderating with you. Laurie's a legend in this area, pioneer. And the questions that we did not get, we'll get them to Helen to provide answers. And we thank everybody for tonight and hope everybody has a blessed evening.